So coming to our patient, yeah.
Summary: 57 years post-menopausal, P4, L4, previous 4 normal vaginal delivery with 2 home deliveries with inter-pregnancy interval less than 2 years. Came with complaints of mass descending per vagina with urinary disturbances. On examination, uterovaginal prolapse, cystocele, rectocele and introcele noted.
So you want me to tell what are the anterior compartment, anterior vaginal wall? How do you classify the prolapse? Anterior compartment, what do you see? Anterior 2/3 is the?
Anterior 2/3 is cystocele, ma'am, and anterior 1/3, in lower 1/3 is urethrocoele. In posterior compartment, upper 1/3 is enterocele, middle 1/3 is rectocele, and lower 1/3 is lax perineum.
Or perineocele. So previously we used to say rectocele and then perineocele. There is a whole descent of the perineum as well. Yes, and the central compartment you have?
We have apical prolapse, which is uterovaginal prolapse, and then we may have wall prolapse in previous hysterectomy cases, and there can also.
So previously enterocele was classified in the posterior compartment, but nowadays enterocele has come into the apical compartment because that is the one with uterosacral not being suspended. Then enterocele will come. So it is coming in the apical compartment,
and
right?
we also have cervical descent in the middle central compartment.
That's right. So now this is a 57-year-old. She has come with main of urinary symptoms. She has discomfort, and you have to assess her whether you need to go ahead with the surgery or she is comfortable doing. We have to assess whether you need to give a conservative management or whether she want to go ahead with surgery. Depends on conversation and extensive counseling. You have to make a clinical diagnosis. Come to treatment plan as to how to proceed. Okay. Next slide. So this is a modified Oxford scale. She has already explained. So this is a method to detect an enterocele. You have, can you explain for the benefit of the students, Aishwarya?
Yes, ma'am. Enterocele, to differentiate the enterocele and rectocele, we are going to put one index finger inside the rectum and the left index finger will be on the vagina. And if we are able to palpate some intestinal loops in between those two fingers, it will be an enterocele. And when the index finger and the rectum can...
and make the patient cough. So if the impulse is on the pulp of the finger, it is enterocele. And if you have the impulse in the tip of the finger, it could be a rectocele here. So if you do a digital examination, this is in this position, in this position, if the impulse is going to be on the tip of the finger, you get the enterocele. But you are going to keep a thumb on the perineum and the index finger. Then if you feel if it is in the pulp, you will get the rectocele. So you have to make the patient cough and find out whether it is enterocele. What is the other method of detecting enterocele? We told is a Sims position. Introduce a Sims speculum and retract the cervix forward and make the patient cough. If the swelling appears in the upper 1/3, that is enterocele, and lower 1/3, it is the rectocele. Yes. So we basically need to know the supports of the uterus, isn't it? So can you just tell me, Sneha, what are the supports of the uterus?
First, uterus is maintained in anteverted position, ma'am. There is angle of anteversion and anteflexion. It maintains the uterus in position, which also prevent the prolapse. And there is a muscular support, which is levator ani muscle, ma'am. Levator ani muscle has 3 parts, which is pubococcygeus, iliococcygeus, and ischio-coccygeus. Pubococcygeus and iliococcygeus supports, whereas ischio-coccygeus is not involved in the support. Pubococcygeus, it has 3 parts, which is called as puborectalis. Based on the attachment, we say that if it is attached to vagina, it's called as pubovaginalis. Attached to perineal body, it's called as puboperinealis. Attached to the anus, it's called as puboanalis.
Yeah. It arises from the pubic symphysis, encircles the genital hiatus. You have pubourethralis, pubovaginalis, puborectalis forms actually a sling. And some fibers go down to the perineum and you have a puboperinealis as well.
Also, the levator ani muscle, it has a resting contraction, ma'am. This resting contraction.
So this is the only voluntary muscle which is always in the resting tone is high. They have a combination of both slow twitch and fast twitch fibers, and always it is in the resting tone is high. Because of that, it prevents the herniation of the bowel and the vagina and the urinary bladder outside. So it forms a platform in the pelvis in which the genital organs rest, the reproductive organs rest, and it prevents the herniation of the genital organs to the outside. So it's not only the levator ani, the fascia covering it, isn't it?
Yes, ma'am. Endopelvic fascia, it's triradiate fascia, uterosacral.
No, first of all, you have to tell about the superior fascia. That is the endopelvic fascia that covers the superior aspect of the levator ani muscle, and it gets condensed to form the condensations of the fascia, like arcuate, wide fascia we call it, isn't it? That extends from where to where?
It extends from the anteriorly from pubic bone, iliac bone, and it goes posterior to the ischium.
Ischial spine. So that is called as arcus tendinous fasciae pelvis, or the condensation of the endopelvic fascia over the superior surface of the levator ani. Okay. So now this fascia along with the levator ani is very important because it just gets condensed and it makes a thick platform on which the pelvic organs rest. So this is a diagram in which you can see the 10 circles. It's a lateral view in which you can see the sagittal view in which you can see the pelvic organs, the genitourinary hiatus being encircled and tightly held in place by the condensation of the pelvic fascia.